Do you have hypertension, elevated cholesterol, or triglyceride levels, or high blood sugar? Or maybe even all of these, and your most recent lab results look like this there? Well, you're not alone. All of these are extremely common major risk factors for several chronic diseases, and it's also not a coincidence that these conditions often develop together around the same time. In this video, I will discuss the root causes of most cases of hypertension, elevated cholesterol and triglycerides, as well as prediabetes and type 2 diabetes. At the end of this video, you will be able to confidently interpret your own metabolic lab results with the help of this downloadable sheet that I've developed. You'll understand why your lab results so often get worse over time and eventually lead to full-blown hypertension, type 2 diabetes, or sky-high blood cholesterol levels. And I'll explain how all of these are part of what I call the insulin resistance syndrome. Hi, welcome to Nourished by Science on YouTube. My name is Mario, and on this channel we are discussing evidence-based nutrition for the prevention of chronic disease. In this video, we'll talk about the insulin resistance syndrome and its long-term consequences. I'm going to share how I define this insulin resistance syndrome and why this constellation, this syndrome of associated risk factors, is probably the most important link between our diet and lifestyle and the development of chronic diseases such as type 2 diabetes, heart disease, stroke, kidney disease, liver disease, cancer, and quite possibly some neurodegenerative diseases as well. I'm going to illustrate the emergence of the insulin resistance syndrome by looking at Joe Average here, as he is aging from 35 to 50 and then 65 years old. We'll be looking at his labs and consider what is happening inside his body that so often leads to very similar changes in almost all adults as they age. So let's take a close look at Joe as he ages to understand what may be driving the emergence of the insulin resistance syndrome. We start with Joe in his mid-30s. He is of normal weight and plays soccer with his buddies a couple of times a week, and he works out at the gym, and he generally feels very healthy. He just had his annual doctor's visit, and these here are his lab results. His body mass index, or BMI, is in the healthy range, which ranges from 20 to 25. Similarly, his waist circumference is in what I would call the optimal range. HOMA-IR, a measure of insulin resistance that we talked about before, is perfect at 1. So Joe is not insulin resistant, or we could also say he is perfectly insulin sensitive. Fasting glucose, which should be under 100 milligrams per deciliter, is also in the normal range. HbA1c, which is a measure of Joe's average blood sugar levels over the last 3 months, is 4.8%. His blood pressure is a bit on the low end, which is probably perfect for his long-term cardiovascular health. Similarly, his fasting triglycerides and LDL cholesterol levels are far below the upper limit of normal, and his HDL cholesterol also looks good. And then we have high sensitivity C-reactive protein, or CRP, which is a general measure of inflammation in the body. In 35-year-old Joe, it's all good with a CRP level of 0.1 milligrams per deciliter. Now, as you can see in red, I have not given the usual normal reference range, but have provided what I would consider optimal for long-term health. For example, in most lab reports, fasting triglycerides are considered normal if they are below 150 milligrams per deciliter. However, I would like to suggest that you start thinking about all of these measures more in terms of continuous variables and not just consider whether your value is above or below a certain threshold. So for triglycerides, most lab reports would say that anything up to 149 milligrams per deciliter is perfectly fine, and suddenly at 150 milligrams per deciliter, the triglycerides are flagged as too high. I suggest that in perfectly metabolically healthy people, triglycerides are usually below about 75 milligrams per deciliter, and higher levels are already indicative of a bit of a suboptimal metabolic state. This here is how I look at this for triglycerides. I'm showing the official threshold of 150 milligrams per deciliter, at which your doctor would say, your triglycerides are a bit high. But I'm also showing that this is almost never a sudden development, and that we should, in my opinion, start to slowly pay some attention even if your triglycerides climb from, say, 70 in your 20s to 90 in your 30s and 120 in your 40s. No reason to freak out if a value goes up a little bit one year and down another. But if I were to see such a trend in the wrong direction, from year to year or every 5 years, I would take note and ask what's going on, even if a threshold that is considered clinically relevant has not yet been crossed. All of the health markers in Joe look great. He's feeling good, and there shouldn't be any reason for concern. However, Joe, being an average American, has always had a poor diet. More than half of his diet consists of ultra-processed foods. He eats fast food often and enjoys sweets and baked goods, a can of soda or a beer regularly. And by his late 30s, his career takes off, and he has kids, and he feels that he no longer has time to play soccer or go to the gym. So poor diet quality has a lot of negative effects on our health. But for now, let's focus on one thing. If we eat a diet rich in fast food, ultra-processed foods, refined grains, and added sugars, we tend to chronically eat more calories than we spend. That leads to weight gain, and the extra calories are initially deposited in the subcutaneous fat tissue. However, at some point, additional fat can no longer be stored in the subcutaneous fat depot, and instead starts to accumulate in visceral fat depots, that is, the fat depots surrounding the inner organs. And we are also seeing an increase in the amount of fat stored in tissues that are not made for fat storage, such as the liver and muscle tissues. We call this type of fat storage ectopic fat. The accumulation of fat in visceral and ectopic depots is also associated with low-grade chronic inflammation in fat tissues and in the liver. The accumulation of visceral and ectopic fat, as well as low-grade chronic inflammation, is what I consider the main cause of insulin resistance in most people. Check out the video up there where I talk about how this works. One additional negative effect of a chronically poor diet is that it can make insulin resistance, low-grade inflammation, and the accumulation of fat in the liver worse. So I could have also drawn arrows like this here. But let's leave these out for now because this graph is going to become very busy very soon anyway. I also mentioned that Joe stopped working out, and so he's physically inactive, which by itself makes insulin resistance worse. And it also contributes to a loss of muscle mass, which independently induces insulin resistance. Because he's so busy with his job, he's also chronically stressed and struggles to go to bed on time, so he's chronically sleep deprived. Both of these also induce insulin resistance. Now that he has become insulin resistant, Joe's body tries to compensate by producing more insulin, and his blood insulin levels are elevated much of the day. We call this hyperinsulinemia. Chronically elevated insulin levels themselves may actually make fat accumulation in visceral depots and also low-grade inflammation worse. So in a way, a vicious cycle develops. And as long as Joe continues to overeat and continues his poor lifestyle, the situation is likely to get worse over time. There are some other well-known risk factors that are linked quite closely to what is happening here. These include the fasting blood glucose concentration, blood pressure, and fasting blood lipids. All of these are quite closely linked to visceral and ectopic fat deposition as well as insulin resistance. Let me explain the biological processes through which they are linked and why I suggest that they should be seen as part of a syndrome rather than individual risk factors. Let's start with the impact of ectopic fat deposition, specifically in the liver. The liver stores fat as triglycerides, and if more than 5% of the liver tissue consists of triglycerides, then we call this fatty liver disease. Globally, a whopping 32% of adults are estimated to suffer from fatty liver disease. So what we're talking about here affects billions of people worldwide. And having fatty liver disease is a risk factor for liver fibrosis, cirrhosis, and liver cancer. So that is in and of itself a risk factor for chronic disease. So the liver tries to get rid of the triglycerides. The problem is that triglycerides are not soluble in blood. Blood is mostly water, and you can actually try this at home. You could take a glass of water and add some, let's say, sugar or salt. Stir, and the sugar or salt would fully disappear. They would be dissolved in the water. The same would not happen if you added some fat or oil to the water. It would just swim on top of the water, right? So if the liver wants to get rid of the excess triglycerides, it needs to somehow package the triglycerides in a way that they can be transported in the blood. The principal transport vehicle for fats in the blood are lipoproteins. Lipoproteins are round particles that consist of both proteins and lipids, meaning fats. This here is the general structure of a lipoprotein particle. Lipoproteins contain fats that don't mix with water, such as triglycerides, in the center of the particle. They are the cargo in a way. And on the outside, there are molecules that play more nicely with water, such as cholesterol and also certain proteins. The lipoprotein made by the liver is one called VLDL, or very low density lipoprotein. This one is relatively rich in triglycerides, and the more fat is stored in the liver, the more VLDL particles the liver builds and secretes into the blood. One important thing to remember here is that cholesterol is just packaging material to enable the liver to secrete triglycerides into the blood. And that means that the liver may just make a whole bunch of cholesterol from scratch so that it has enough packaging material to get rid of all the triglycerides that have accumulated within the liver cells. Now, in the blood, VLDL sheds triglycerides, which are being taken up into tissues, ideally adipose tissue, for long-term storage. Through that process, the amount of triglycerides in the particles decreases, and the relative amount of cholesterol and protein increases. The particle shrinks, as we see here, and gradually becomes LDL, low-density lipoprotein. In other words, the cholesterol that the liver originally makes as packaging material to transport triglycerides eventually ends up in LDL particles. And this is the cholesterol that we measure in the lab as LDL cholesterol, the cholesterol bound within LDL particles. And this is relevant because the higher LDL cholesterol, the higher the risk of cardiovascular disease. So what you may be able to appreciate now is that in someone with fatty liver, the liver produces more VLDL particles, and these are pretty rich in triglycerides. So if you were to measure the triglyceride content of fasting blood in someone with fatty liver disease, you would find that their fasting triglycerides are usually quite elevated. Because the liver has to make more of these VLDL particles to try to get rid of triglycerides, more LDL particles are also formed, and because LDL are pretty rich in cholesterol, such people with fatty liver also tend to have elevated concentrations of LDL cholesterol in their blood. And now the last piece. There is one more lipoprotein particle that you may have heard about, and that is HDL, high-density lipoprotein. HDL is not made from LDL, but is built outside of the liver and has a totally different function than VLDL and LDL. Now, of interest here is that HDL particles and VLDL particles interact with each other in blood. Whenever there are a lot of triglyceride-rich VLDL particles in the blood, the HDL particles take up some of those triglycerides from the VLDL particles in exchange for cholesterol. So this is another mechanism through which VLDL particles can get rid of triglycerides. However, in that exchange, the HDL particle, they gain triglycerides, but they lose cholesterol. In other words, the amount of cholesterol in blood that is bound to HDL particles decreases. That is why in this constellation of someone with fatty liver disease, we often see this exact combination of elevated LDL cholesterol levels, low HDL cholesterol levels, and elevated triglycerides. In addition, insulin resistance itself, independent of whether someone has a fatty liver or not, seems to contribute to elevated LDL cholesterol concentrations. And insulin resistance is linked to another major risk factor for chronic disease, high blood pressure or hypertension. The mechanism of that effect seems to be, at least partly, that insulin affects the degree to which sodium is excreted through the kidneys, such that more sodium is retained in the body at chronically elevated insulin levels that are typical for insulin-resistant patients. So to summarize, a chronically poor diet that leads to excess calorie intake, particularly when combined with a sedentary and stressful lifestyle, will lead to the accumulation of excess visceral and ectopic fat, as well as the development of insulin resistance and low-grade chronic inflammation. Over time, this constellation will also lead to a disturbance in lipid metabolism that your doctor may refer to as dyslipidemia, and that is characterized by elevated LDL cholesterol, low HDL cholesterol, and elevated triglyceride, as well as hypertension. This constellation of risk factors, all of which are associated with each other, is what I call the insulin resistance syndrome. It is similar to the metabolic syndrome, which you may have heard about. We'll talk later about how they are similar and why I think that the insulin resistance syndrome, as I define it, is more useful for chronic disease prevention. But first, let's talk about why this syndrome is so problematic and discuss the relationship between the insulin resistance syndrome and chronic disease risk. First, as I already mentioned, having excess fat in the liver is a major risk factor for liver disease, often progressing from fatty liver disease to fibrosis to cirrhosis, all of which are also major risk factors for liver cancer. Second, insulin resistance is a major risk factor for type 2 diabetes. Third, the accumulation of visceral and ectopic fat, insulin resistance, and type 2 diabetes are all risk factors for several types of common cancers. Fourth, both type 2 diabetes and chronic hypertension are major risk factors for chronic kidney disease. And lastly, let's look at cardiovascular diseases, including heart disease, stroke, and peripheral vascular disease. We understand the risk factors for these conditions really well, and these include high LDL cholesterol, low-grade chronic inflammation, hypertension, and smoking. And chronic kidney disease and type 2 diabetes, but even frequent blood sugar spikes, as we may see them in prediabetes, are also major risk factors for cardiovascular disease. So let's get back to Joe from earlier and consider how, over time, the consequences of his poor diet and lifestyle manifest in the insulin resistance syndrome and major chronic disease risks. We did look at Joe's health parameters at age 35. Let's now look at his health 15 years later, now aged 50. Joe is now overweight and also still quite sedentary. He is often stressed and many nights doesn't get more than 6 hours of sleep. As a result, his blood work doesn't look all that great anymore. If his doctor were to measure his visceral fat mass and liver fat, he would find that Joe has gained quite a bit of visceral fat and that he now has a mild case of fatty liver disease with about 5% of fat in his liver. However, these are usually not measured, so let's take a look at what is actually measured, or at least could more easily be measured. As a result of his lifestyle, and also the visceral and ectopic fat accumulation, his waist circumference has expanded, and he is now insulin resistant with a HOMA-IR of 3.5. It's not super bad yet, but still, his pancreatic beta cells are not able to fully compensate for his degree of insulin resistance, and he has now also developed prediabetes. That's reflected in his fasting glucose level of 110 milligrams per deciliter and his HbA1c of 6.0%. He now also has slightly elevated blood pressure, and his fasting triglycerides, LDL cholesterol, and CRP are now also quite a bit higher than they were when he was 35. Now, none of these measures are all that bad, and if we consider the clinical guidelines, it's quite possible that none of this would as yet be treated. So Joe continues his poor diet and sedentary, stressful lifestyle. At 65 years of age, he now is obese and very insulin resistant. He also has manifest type 2 diabetes with fasting glucose at 130 milligrams per deciliter and an HbA1c level of 6.8. His blood pressure has continued to rise, and he now clearly has hypertension. And his blood lipids and inflammation markers have gotten a lot worse as well. Now, the clinical guidelines say clearly that Joe should get anti-diabetic medication, and his doctor will probably start him on some metformin. He will also receive medication to lower his blood pressure and his LDL cholesterol levels. With all of these medications, his blood sugar, blood pressure, and LDL cholesterol levels would come down. If you think this is a constructed case and not very realistic, I would have to disagree. I bet every primary care physician in the United States or Europe sees a patient like this almost every day. And most people in most countries will go through this exact trajectory or a variation thereof. Now, what is wrong with this picture? In my opinion, two things. First, this entire time, a time frame of 30 years, the insulin resistance syndrome built up slowly, with all of the major chronic disease risk factors gradually getting worse and worse. Yet, quite commonly, nothing is ever done to address the root cause. Not even at 65 are we usually addressing the real issue here, the poor diet and the sedentary and stressful lifestyle. And look at all of the major components of the insulin resistance syndrome that are at the heart of what is going on here. the insulin resistance, the low-grade chronic inflammation, the visceral fat and ectopic fat. In most people, these are never even measured, so we do not know about them and cannot treat them. Second, we now understand very well that what matters for chronic disease risk is the exposure to a risk factor multiplied by the time of the exposure. So, for example, if the exposure is high blood pressure, then 2 years of having high blood pressure is worse for your cardiovascular health than 1 year. Same for high blood sugar, measures of inflammation, or LDL cholesterol. So obviously, it's good that we intervene and address these risk factors eventually. And let's be clear, once someone has gotten diabetes and such elevated blood pressure and lipids, taking medications is definitely the right thing to do. However, if you were Joe, would you not have wanted to recognize, at the very least, when you were around 50, that your health was moving in the wrong direction? It's never too late, but isn't it obvious that in a case like this, earlier is clearly better? I'd like to be clear that I'm not trying to blame physicians here. Physicians are very much limited by the healthcare systems, insurance policies, and clinical guidelines. And let's be honest, also by what their patients are willing to do for their own health. Also, physicians usually have their hands full caring for those who already have all of these chronic conditions. Physicians also receive very limited training in nutrition and lifestyle medicine. No, what I'm really getting at is that we all should accept more responsibility for our own health. It's certainly easy and partly justified to blame the food industry, fast food companies, marketing campaigns for unhealthy foods or the higher costs of healthy foods. I know it's hard because this environment we live in oftentimes makes it difficult for us to consistently make good choices. And of course, there are a lot of inequalities in this world, and some people have bigger challenges to overcome than others for sure. But it doesn't help us to complain and do nothing. Our biology is what it is, and if we mistreat it for years and years, it will come with a price. Let's take a quick look at Joe at 65 with the lab data we just discussed and assess his risk of developing heart disease, such as a heart attack over the next 10 years. I entered some of those data into a risk calculator that's run by the Mayo Clinic. I'll leave a link in the description box below. Joe's risk of having a heart attack over the next 10 years is 39.4%. That, to me, is scary. What if he takes the medications his doctor prescribes? If he takes the metformin, his blood sugar will be better controlled, and his blood pressure and LDL cholesterol also come down if he takes the lipid-lowering medication and an ACE inhibitor. Still, his 10-year heart disease risk remains high at 29.7%. Now let's assume there was a parallel universe in which Joe had made efforts to eat well and exercise regularly since he's been 35. This would be Joe and his lab values at 65. All of the values are still within the green, close to the optimal range, and his 10-year heart disease risk would be estimated at 8.7%. Now, that risk calculator is pretty good, but it does not consider several known independent risk factors, including high sensitivity CRP and insulin resistance. So if anything, the risk calculator underestimates the actual difference in risk between the unhealthy Joe and the healthy Joe. Still, these data suggest that healthy Joe's heart disease risk is a whopping 70% lower while not taking any medications. So how can you determine if you suffer from the insulin resistance syndrome? Let's start with the metabolic syndrome. As I mentioned, the metabolic syndrome is a clinical diagnosis, and it is based on these 5 factors listed here. I have shaded that area in gray. Your doctor will make the diagnosis of metabolic syndrome if, for at least 3 of these 5 risk factors, you reach the level that is underlined. Now, there are 2 things I don't like about the metabolic syndrome. First, I personally think it doesn't make sense to define just one threshold. Everything under that threshold counts as okay, and then everything above that threshold counts as equally problematic. As an example, per the definition of the metabolic syndrome, fasting triglycerides of 70 are considered about the same as 145, right? Because they're both in the okay range below the threshold of 150 milligrams per deciliter. But then 155 is considered problematic, and triglycerides of 300 are considered just as problematic as 155. So personally, I think it is much better to define rough ranges for optimal levels versus mildly elevated risk versus massively elevated risk, which is what I've tried to do here with these colors. Which exact values we use as anchors for optimal in the green portion of each bar and as massively elevated risk in the red portion of the bar is certainly debatable. So what you see here is simply my suggestion based on my interpretation of the literature. But to stay with the example of fasting triglycerides, anyone could now compare where their triglyceride level falls on the scale. Optimal or close to the optimal here in the green portion of the scale, mildly elevated somewhere here in the orange portion, or massively elevated around 200, 225 milligrams per deciliter or higher. The second thing I don't like about how the metabolic syndrome is defined is that it includes fasting glucose, but not what I would consider the earlier and more fundamental change in glucose homeostasis, insulin resistance and hyperinsulinemia. Because, you see, in the early stages of people with this syndrome, whether we call it metabolic syndrome or insulin resistance syndrome, people first become insulin resistant. And they are always insulin resistant to some degree because insulin resistance is a central part of this syndrome. Glucose intolerance may or may not develop, depending on whether an individual can compensate for their degree of insulin resistance by secreting more insulin. But I certainly feel strongly that insulin resistance is a primary defect here in this syndrome, and glucose intolerance only a secondary one that may or may not manifest. For the same reason, I would also include high sensitivity C-reactive protein because low-grade inflammation is a key component of this syndrome, and I would also include LDL cholesterol because it is such a key risk factor for cardiovascular disease and so clearly linked to liver fat content and insulin resistance. Let's use these graphs and take another look at Joe, our example from earlier. I've taken Joe's lab values from his physical at 35 and entered them here in this graph. And we can see nicely that his risk factors are all in the green. If we now add his data at 50, we see that they have all shifted into the orange territory. And if we had done this at 40 or 45 years of age as well, the dots would have been somewhere in between, maybe like this here. At 65 years of age, all of his risk factors are now strongly in the red. And I hope from my explanations earlier, you now understand that it is not a coincidence that these risk factors tend to shift together. It's not always this clear, of course, but because all of these are linked to insulin resistance and ectopic and visceral fat accumulation, they tend to be strongly associated with one another. I hope this also illustrates why it is better to understand what optimal looks like so that we can recognize shifts away from optimal sooner and intervene if we're so inclined. So I'm hoping this poster can be practically useful for you. This poster here is specifically for white men, but I have also created versions for white women and non-white men and women. That is because depending on your race and gender, some of the data need to be interpreted slightly differently. You can download all of the different versions of these posters for free. The link is in the description box below the video. Once you have had your next annual physical exam and get your lab results from your doctor, ideally these should include HOMA-IR. I explained in the video linked up there how this is determined. And then print out the appropriate sheet for your gender and race and enter your data in this fashion here. Are you mostly in the green? Yeah, maybe give yourself a bit of a pat on the back. This is where you ideally want to be, such as Joe here at 35, or a little less ideal, but still not a huge concern, even Joe at 40. And by the way, if you can't get HOMA or CRP measured, this exercise still holds value even if you just have 6 or 7 data points. If your lab results fall mostly into the orange portion of these bars here in the middle though, such as Joe at 45, 50 or 55, then you are clearly on a path that could lead to full-blown insulin resistance syndrome. At this point, it's still mild to moderate, but this is where your doctor may start to suggest a lipid-lowering or blood pressure-lowering medication. And I think the biggest benefit to graphing the data like this is that you can see where this is going. And this is a great opportunity to decide whether you want to continue on this same path or maybe make a course correction. And if you're mostly in the red, I hope this motivates you to work with your doctor to control these risk factors, but also to do some work yourself towards addressing the root causes of the syndrome. Okay, that's it for this video. Thank you for watching. If this was of interest and useful to you, please consider leaving a like and also feel encouraged to share this video with friends or family members who you think may be interested. Thank you very much. Take care.